Hi everyone. I'm going to give you an overview of the neuroscience of substance use disorders, and I'm going to try and do it in less than 15 minutes. Okay, you can see in this first compilation of images that really in just the last several decades, we moved exponentially toward understanding the nature of compulsive drug use and drinking, the etiology of substance use disorders, and subsequently better improved treatments to help people struggling with addiction obtain and sustain symptoms-free lifestyle for longer periods of time, aka recovery. So what does the science tell us about addiction? Well, really, in just the last 15 years or so, advances in science has revolutionized our fundamental views of what is now more accurately called substance use disorders. We really don't use the term addiction for drug and alcohol use because it's not accurate, and it doesn't describe the health condition very well, and it has a lot of stereotypes, stigma, and emotional baggage attached to it. And the science-based understanding really has allowed for the development of improved treatments, including new pharmacotherapies called medication-assisted treatments. It all starts in the brain in an area called the mesolimbic pathway, and some references call it the mesolimbic dopamine pathway. But regardless, it's the brain's reward system. So the mesolimbic pathway, the MLP, is hardwired in all animals, and it's fundamental for survival. So apparently there's a need for the neurological system allowing for the awareness of various biological tensions such as hunger, thirst, socialization, mating, nurturing, etc. And these biotensions, if you will, lead to specific behaviors that seek and find relief from those stressors. For an example, thirst and hunger are tensions, and having consumed water and having eaten are behaviors that find the relief from the tensions of thirst and hunger. And among other things, when the behaviors occur that result in relief from biotensions, the MLP releases brain chemicals called neurotransmitters, including dopamine. And they motivate behaviors that result in the relief from these biotensions. And these behaviors are then reinforced, another function of dopamine, and will occur repeatedly when the biological tensions and stress recur. Here's a slide showing you the divisions of the brain that make up the reward circuitry. So these three areas, there's actually a couple of others, the insula and the amygdala, but these are the three major dopamine areas that make up the MLP brain reward circuitry. The feeling of pleasure is how a healthy brain identifies and reinforces beneficial behaviors, such as eating, socializing, sex, nurturing, socialization. Our brains are wired to increase the odds that we'll repeat pleasurable activities, and dopamine neurotransmitter is central to this. Whenever the reward circuit is activated by a healthy, pleasurable experience, a burst of dopamine signals that something is important happening and needs to be remembered. Here's hungry, having eaten. Dopamine rush in the MLP reinforce the behavior. The next time the tension of hunger occurs, it just automatically signals the behaviors of eating. So the dopamine signal causes changes in neural connectivity that makes it easier to repeat the activity again and again without actually even thinking about it, leading to the formation of habits. Just as drugs produce intense euphoria because they act on dopamine, they also produce large surges of dopamine that powerfully reinforce the connection between the consumption of the drug, the resulting pleasure from being under the influence, and all of the external cues linked to the experience. And large surges of dopamine, in a sense, teach the brain to seek drugs at the expense of other healthier goals and activities. Drugs interfere with the brain cells, or neurons, how they send, receive, and process signals via neurotransmitters, and can alter important brain areas that are necessary for life-sustaining function. and they can also drive the compulsive drug use that marks severe substance use disorder. Drugs will mimic neurotransmitters in a way that can cause both structural and long-lasting functional changes in the brain. And here you can see that morphine really acts like endorphin, a natural endorphin, by triggering changes in that part of the brain. And the brain doesn't just tolerate that, it tries to counter that. And that's where the problem begins. And here's another slide showing that the natural endogenous, or from within, neurotransmitter of anandamide triggers changes in our natural endocannabinoid system, but so will THC. So drugs that mimic neurotransmitters will cause changes in the brain, but over time will cause structural and long-lasting functional changes, possibly. So what gives the drug an abuse potential? Drugs with abuse potential target the MLP, the reward system, and overactivate dopamine system to levels that are unsustainable. Research shows that repeated drug use changes the brain in fundamental and lasting ways. So most drugs don't have abuse potential. You know, the physician's desk reference has thousands of different medications and drugs, but really only about 25 or so have what we call an abuse potential. And so what gives a drug abuse potential? Well, you know, it's got to target and activate dopamine systems in the MLP. Most drugs don't do that. Repeated drug use can ultimately cause a dopamine deficiency. That's the downside. That's the dark side of addiction. That initially, when there's sufficient dopamine for the drug to act on, there's a feel-good response. But the brain can't keep up with the dopamine production needed to sustain pleasure. And pretty soon, there's drug-induced dopamine deficiency, which causes depression, anxiety, lethargy, agitation, craving, and irritability. And these drug-induced additional biotensions now are caused by and exacerbated by continued drug use. And the brain has mechanisms to counter this change in an attempt to re-regulate itself. Our brains are driven to find and regain balance. And the development of tolerance and withdrawal are attempts the brain makes to do that. So these case histories here show us something about substance use disorder. Case 1, a 16-year-old woman was brought to the hospital emergency room. She got into an argument with parents and ended up throwing a chair at them. There was a concern about her being under the influence at the time. Case 2 is a 33-year-old male referred to residential treatment. He told his intake counselor that he has a 6-year history of heroin use and he drinks 3 Magnum bottles of vodka per day. He's married with 2 kids, but was kicked out of the house 3 months ago due to his drugging and drinking. And case 3 is about a 76-year-old widow who lives independently by herself. She's been increasing her alcohol use from the usual 1 highball in the afternoon to now include 2 to 3 throughout the evening because she says it helps her sleep. So what do these case studies show us about substance use disorder? Well, persons with this disorder are not just a generic group of people who simply drink and use in excess. Nope. The research and our clinical experience shows us that there's actually several subtypes, each with a different etiology or cause of a condition or disease, and subsequently its own unique and individualized treatment care plan. There's no more one-size-fits-all approach anymore, thankfully, because that never really worked. So diagnosing substance use disorder, we look to the DSM-5, the Diagnostics and Statistical Manual of Mental Disorders, easy for you to say, 5th edition. And in this manual of diagnosable mental health conditions, it's now referring to addiction as substance use disorders because it more accurately describes a continuum of severity from misuse to problem use, dependence, and chronic relapsing disorder, what we used to call addiction. And there's 11 diagnostic criteria or symptoms over a 12-month period, and it allows now for the clinician or the counselor to determine the severity subtype. So with only 2 to 3 symptoms, it will probably be a mild subtype of substance use disorder. Same diagnosis, but not as severe as other types. And 4 to 5 positive symptoms of the 11 would be a moderate, and then 6 or more symptoms over a 12-month period would be severe. And this allows for a new paradigm where treatment is individualized based in part on the subtype and the severity levels. Here's the 11 symptoms. I won't go over them because time is a-ticking. But you can boil these 11 symptoms of DSM diagnosing substance use disorders into 4 C's. Well, the first C is that there's control, or actually lack of control when they use. There's compulsion to use, there's continued use despite negative outcomes, and there's craving. Reminder to counselors, continued compulsive illicit drug use despite negative medical, legal, personal, social, or occupational consequences is a diagnostic cornerstone for substance use disorder. So what increases the risk? Doesn't cause, increases the risk. Genetics, environmental, age of first use is a risk factor. And also check out the ACEs, the Adverse Childhood Experiences. Fascinating longitudinal study. And co-occurring psychiatric conditions, particularly depression, schizophrenia, and bipolar, all increase the risk for substance use disorder. Can treatment help? Absolutely. Is it very effective? Yes. And the outcomes are about the same as those from other chronic conditions. And the most evidence-based treatments compared to generic one-size-fits-all approaches or placebo are these. MI, contingency management, which is incentives, cognitive behavioral therapy, couples and family, 12-step facilitation, not 12-step meetings, that's not treatment, but 12-step facilitation management, and then medication-assisted treatment. It's medication-assisted treatment with behavioral therapies is the most successful treatment we can offer these people. How do meds help treat substance use? Well, they reduce craving and withdrawal. They help clients stay in treatment, and they prevent relapse. And you note this meta-analysis by the Pew Charitable Trust. And the Pew Research is actually one of the many fantastic research entities. Go ahead and Google them as well. But their meta-analysis on treatment outcomes shows that the most effective intervention to treat opioid use disorder is medication-assisted treatment with counseling. And it's more effective than either counseling or meds alone. Wow. So we need to expand the access to treatment because most of our treatment is targeting the most chronic and severe relapsing type of substance use disorder. But most people with the diagnosis of substance use disorder aren't the chronic relapsing type. And yet most of the treatment programs are targeting that chronic severely addicted type. So we have to bring substance use treatment into other arenas than the traditional programs that treat just as severe. And that would mean moving the substance use treatment into medical care settings and hospitals, emergency rooms and trauma centers, perinatal clinics, OBGYN offices, medical specialty settings for diabetes, liver and kidney disease, pediatrics, schools and college health centers, and certainly mental health clinics. So I think I did it. I think we got it under 15 minutes. And thanks for watching. I really hope this was helpful. And until next time.